Hello, so my name is Major Brian Sindelar. So I'm an active duty neurosurgeon at Triple Armory Medical Center. First, I'd like to thank everyone for the invitation to really speak among giants of neurosurgery, specifically within the realm of severe TBI. And it's an honor to give a discussion really focusing on severe TBI within the military, and I think how this can be used in the civilian realm. So, of course, I have no disclosures, and the views discussed here are that of the, don't represent the Army, the Department of Defense, or the US government. So I'd like to kind of get from this is to really discuss the epidemiology of military traumatic brain injury over the most recent conflicts, review the pathology of blast TBI, and then emphasize the main differences between managing military versus civilian TBI. And then honestly, actually critique the literature that guides right now the military TBI management and operational decisions. So traumatic brain injury within the military has demonstrated an increasing prevalence over the past couple decades, really due to our prolonged involvement in Afghanistan, Iraq, the ever-increasing exposure to blast-type injuries, specifically from IEDs, improvised explosive devices. And then also really because of our improvements in body armor. So this is actually reducing the once very lethal chest injuries and abdominal wounds that was associated with blast injuries. And so we're now seeing these soldiers with the cranial injuries. So of a review of the DoD trauma registry from 2001 to 2018, there's a total of 7,000 reported traumatic brain injuries, in which 9% were actually classified as severe. That mortality actually reached 20% within that group. In comparison to civilian TBI registries, as expected, theater TBI has a large volume of penetrating TBI due to the exposure to improvised explosive devices. Though very challenging in the military system to really try to maintain these databases, I think it's truly vital in order to improve our outcomes in military TBI. Because honestly, an application of civilian data, I would argue, is really not even applicable in this type of injury. So here, as Dr. Okonkwo was discussing in his presentation, here are 3 radiographic images of patients from your typical civilian trauma center that are suffering from what would be classified all as a severe TBI, but are very heterogeneous grouping, as they all have very different prognostic outcomes and even management algorithms. We frequently then discuss the challenges of obtaining strong clinical evidence to guide management of these because of the significant assortment between them. This becomes even more complicated with military TBI because, as we see, these injury patterns can become quite complex, really occurring in environments where there's even very limited surgical capacity. So when an explosive detonates, there's a high positive pressure wave that travels away from the source within a matter of milliseconds. And you can see up in the top right corner, that's the Friedlander curve of this significant positive pressure wave that then you get a negative pressure wave shortly following. This wave then creates injuries to a soldier that can be composed of both blast, blunt, and also penetrating TBI, through primary injury, which is from the blast wave itself, from secondary injury, that's actually from the debris or shrapnel hitting the soldier, tertiary, that's the displacement of the body then hitting objects, and then also other things like radiation and burns. So specifically, I want to touch on primary injury pattern of blast wave injury, because this is typically not discussed within civilian TBI. And I think we too frequently try to apply what we learn in the civilian realm to blast TBI. So there are multiple theories of what truly causes injury within the cranium following exposure to a blast wave. The well-known acceleration mechanism is when microscopic and macroscopic translational rotational acceleration of the brain tissue results in diffuse axonal injury, subdural hematomas, and or parenchymal contusions when the brain strikes the skull. So this is very similar to a typical traumatic brain injury seen from like a motor vehicle accident. There's also direct cranial transmission of the pressure wave. It's been believed to be postulated to create a compressive wave via the CSF. There's also what we call a spalling effect, where heavier tissue densities travel at different speeds, creating injury at the gray-white matter junctions. And then even this new phenomenon that's really an implosion type phenomenon through cavitation that you can see at the bottom right. And then lastly, the accepted, really the less accepted proposed vascular surge, where in animal models, we've actually seen the pressure wave be transmitted through the cardiovascular system from the thorax into the intracranial space. So for this reason, I think we always need to be really cautious when applying research in blunt TBI to blast wave injury, for example, with TBI biomarkers, because the pathology of the injury is even more complex and poorly understood. So aside from the differences in injury pattern between military and civilian TBI, the cohorts and even surgical equipoise, I think, is very unlike. Though the typical military and civilian trauma patient is of a younger age with limited medical comorbidities, I would still argue that the physical fitness level and overall health of a soldier is likely better than the average 20-year-old American, and this could theoretically affect long-term morbidity mortality. Du Bois et al. Performed an age-matched cohort comparing military severe TBI patients to a group of civilian counterparts to demonstrate an overall improved survival, kind of at first glance. Interestingly, he also demonstrated a significantly higher rate of surgical intervention in the military group, but with improved survival. So this seems somewhat counterintuitive. Is it that our threshold for surgery is different? You can ask a lot of different questions, but I think this ultimately comes down to the role of surgical intervention in the military is quite different than that in the civilian realm in a patient that suffered from a severe TBI. So for example, think of a combat support hospital in Baghdad with limited operating room availability, a very small ICU, sometimes finicky CT scanner, and also operative supplies to just do very basic trauma work. So therefore, the goal in theater is to perform only life-saving operations at the combat support hospital, but also to stabilize them for evacuation to a level 4 hospital. So that's one of the larger hospitals, in the continental US or in Germany. But this involves sometimes a 6 to 18-hour flight to get there. So therefore, the algorithm for when to perform a decompressive craniectomy or place even monitoring or EVDs on a soldier is quite different than in a civilian patient who is in a neuro ICU receiving Q1 hour neuro checks with the possibility of emergent 24/7 surgical interventions. So as we discussed by the previous presenters, there's an escalation of medical therapy prior to considering a decompressive craniectomy in the civilian trauma center. But from the lessons we've learned in Iraq and Afghanistan over the past 20 years, management of military TBI due to the nature of blast injuries and also the requirement of prolonged medevac, medical therapy is not always maxed out, and we kind of reach towards having a lower threshold to perform a decompression with the purpose to protect the brain from significant alterations in ICP, even during altitude flights, and also, all in efforts to prevent secondary neurological injury. So for a military specific guidelines, we have the Brain Trauma Foundation recommendations that were actually published back in 2005, and then the Joint Trauma System Clinical Practice Guidelines that were published in 2017. The JTS guidelines honestly really just mirror the civilian severe TBI trauma foundation guidelines regarding CPP and ICP goals and use of anti-epileptics that were previously discussed. The JTS TBI guidelines, what I want to point out is, and I think how this is applicable to the civilian neurosurgeon, is dealing with penetrating TBI. So there is a recommendation for broad spectrum antibiotics for penetrating TBI with a length kind of really determined by the practicing provider. Also the need to keep EVDs and ICP monitors until the medevac occurs so that you can have continuous monitoring of the patient during this long flight. As discussed, having this low threshold for EVD and ICP monitoring and also decompressive craniectomy. This can either be through reverse question mark incision, or Dr. Sai discussed the bifrontal craniotomy. Another thing that's kind of making a resurgence within the military is doing this Kempe incision. And so really the purpose of this is just to spare the auricular and occipital arteries. Also limits the kind of the dependent portion of the scalp incision, just because of the reverse question mark incision was seeing a lot of breakdown. Other discussion, which is kind of beyond this presentation, is really what to do with host nationals with a poor GCS score. And there is a discussion about really considering kind of what supplies we have, what's the mission involved, to consider surgical versus medical and expectant management. The challenges with these, Afghani nationals is we can do the surgery and we can save their life, but the care that's going to be involved in having those resources at a civilian hospital is very limited. So another guideline stated by the JTS is when to consider exploratory burr holes and potentially converting to a craniectomy. I always think this is interesting to bring up among civilian neurosurgeons because sometimes this is kind of shocking to even consider to do. But sometimes, we don't have capacity to have a CT scanner. Typically, this is, a Role 3 hospital will have a CT scanner and will have a neurosurgeon. So actually, these guidelines are more intended for a trauma surgeon that is far forward in close proximity to the battlefield. I still really kind of question the utility of a trauma surgeon performing a cranial operation, because even in our own literature, there is some questions of the utility of these aggressive measures in TBI, even in the hands of a very experienced neurosurgeon. So the utility of this being done by someone that's never turned a craniectomy flap, I think, is concerning. So other kind of points to make when managing penetrating TBI is, again, as Dr. Sai mentioned, having the wide decompressive craniectomy. This really comes from the civilian literature, being either unilateral versus bilateral. When you're dealing with, you're in a country that if you do the surgery and then US forces then remove from this country, the challenges of actually having them get to a neurosurgeon to then do the cranioplasty, it can be difficult. So in the military literature, there is discussion of doing this hinge craniotomy, where you can see here that you plate it in such a way that when the brain swelling comes down, that flap theoretically can get pushed back into the defect. As you can imagine, there's then challenges to this of making sure that there is enough room for the brain to have external herniation and relieve ICPs. One of the things that over the years, actually Harvey Cushing, the father of neurosurgery, was involved in, he was in the military. And there was a lot of discussion about primary dural closure versus, how aggressive to be with this. And there's a lot of concerns with penetrating TBI of infection. And this has actually changed to being, very standard to what we do in civilian trauma, of just doing onlays with dural substitutes and just having a good skin closure. Also, the importance of identifying sinus involvement and then the need for cranialization. Here, this is kind of what I already mentioned about management of bone flaps. So if it's a penetrating injury within the military, we actually do not save the bone. And they then get a synthetic cranioplasty when they reach conus. If there's blunt injury, you can then just place it in the abdomen, as we typically see in civilian hospitals. And then host nation, what we discussed.